I've got a primary reg, which is dead important for doing the central bearing tracing later. That helps us set up this. The primary reg at visit 2 is nothing to do with prescribing where the teeth are going to go. It'll all make sense in a minute. So now everything I'm talking about tonight is in handouts. So if you just go to, you can go to my speaking page at finlaysutton.co.uk, click on that, on the speaking bit. So you click on the speaking, scroll down the page, and you'll find here a handout which has my complete denture construction manual. And it's also got, which this manual here explains everything how I do dentures, and also all of the material and equipment I use, and also lots of photographs of tonight's presentation. So you can actually talk, you know, with your technicians about exactly what you're wanting. So visit 1, I do these primary impressions. These are in the 2-part material. You can look at that up in the construction manual. And then for visit 2, I get an upper tray, which is spaced for alginate, and a lower tray, which is close fitting for zinc oxide eugenol. And that lower tray is designed in a very specific way. And the way to design that is in the construction manual. And you can, if you just follow the 6 steps, that will help you to design a special tray which makes the denture fit amazingly well. Out of the whole of today's talk, that is the most important slide of the whole thing, is that on its own, and it's in the construction manual. So that shows you how to make this special tray. So these are Lynn's, this is visit 2. So that's the upper alginate impression, definitive, and the ZOE definitive lower impression, zinc oxide lower. So now at visit 2, I also do the primary jaw registration. So this is done at visit 2 at the definitive impression, and it consists of an upper rim here, wax rim, and a lower Manchester rim, 2 little pivots like that. And what I do with this is I do the primary jaw registration with those pivots at visit 2. And all I'm doing is recording Lynn at the correct occlusal vertical dimension. So, and all that is doing is to enable us to set up the Gothic arch tracing. So that's trimmed to the right occlusal vertical dimension. I fix that together, and then this allows Rowan to mount the definitive casts. It mounts those definitive casts using that jaw registration. So this helps then, from that, Rowan can then set up this thing, which is this is magic, this is the Gothic arch tracing, and it has a plate and a pin on it, and it's fantastic for recording really accurately the centric relation. It's way better than doing it with registration rims that we're taught to use. So if we now go to visit 3, we've got our rims. Rowan gives me this here. So these are new rims which are made on our definitive models. So these are used for prescribing the tooth position and verifying the correct OVD for the patient first. And then the central bearing apparatus helps us to record centric relation really accurately. So this is visit 3. So I trim the rims for the correct tooth position at the correct occlusal vertical dimension. So here's Lynn. This is what we've done. So we've carved the upper rim perfectly using 5 steps: lip support, incisal plane, occlusal plane, buccal corridors, centerline. Now, she did not want to look like, or have her teeth look like, her natural predecessors, but she did want them to look like her daughter's. So we used her daughter's teeth to copy and arrange the teeth. So Rowan used that later. So that goes to Rowan for later, that particular photo there, so we can arrange the teeth. Now, the rim itself here, because this is now the correct OVD, absolutely bang on. What I do is at this appointment, I take that out of the mouth, put them back onto the articulator, and I make sure that the incisal pin here touches at the same point as on here. So the vertical dimension on the articulator is the same as the mouth. I then take off these rims and I put on the central bearing apparatus, and then there's a little screw here which I can turn up and down, and I get that pin touching at the same time as the incisal pin here, so that the Gothic arch tracing is at the exact OVD as our registration rims. I can then take this to the mouth and then get and record centric relation perfectly. And I want to share with you exactly how I do that now. This is amazing, this thing. So we've got a plate at the top and then the pin at the bottom. What I do is I put a China graph mark on the upper plate. It says China graph. So I warm that up and then I take this to the mouth here. So it goes into the mouth. And then I get Nancy to go, Lynn to go forwards and back, forwards and back. And that back position is centric relation. All over. So I get to move everywhere, all over, really go for it. And the back position is centric relation. Let's take it out and have a look. I always love this. It's so exciting when I take it out. So you can see here that arrow, which has actually formed a point, that there is centric relation exactly. And I put a plastic disc over that to go over the apex of the triangle. Take this to the mouth and then squirt Futar D in between the two. So what I've done here is I've got Lynn to just close up into that hole there, and then I squirt this in. So I inject that in, and this locks it together beautifully there. And then I take that out just like that. And it's so solid, it's so accurate. And then we mount the carved upper rim on the articulator using the face bow transfer. That gets fixed on here like that. Rowan takes that off, and then our central bearing apparatus is fitted underneath perfectly in centric relation. So this means that the teeth are set beautifully intercentric, and I find that the bite's really so accurate with doing this. It's lovely. So let's go to the try-in now. So this was try-in here. And this is the arrangement. Can you remember it looked like her daughter's teeth with the lateral incisor set in here. Lynn hated this. She did not like the look of it at all. So at this point, we always do a video of the patients as well so they can have a good look at themselves. She did not like that. So she wanted it making more even. So we went to try in 2 here. So we brought the lateral out here, but kept a similar arrangement to her daughter's teeth. She didn't like that either. She wanted the centrals level and lifting. So, and her wish was to have like really natural looking teeth, but we were heading towards a denture. Here we've got trying 3 here. Is she happy? She's good to go. She was happy with that. So this was the wax try-in Mark III, but it looks like a denture, doesn't it? Not fantastic, but okay. It was all right. So anyway, so we went to finish now. So these are the dentures finished. So we've got the full upper acrylic base denture, and in the lower, we've got it with Monoplast B soft lining on there. Now, Lynn, she also had a really pronounced gag reflex. I didn't need to use acupuncture for her for doing the impressions, but we had to really manage her very carefully during that impression process. So Claire held her hand, we counted her down, breathing through the nose, wiggling the toes, etc. And with these sorts of cases as well, with complete uppers, I compromise on the post-down position, and I compromise in the middle. I can bring that post-down further forward, but I sweep it around the back of the tuberosities like that, keep having it fully extended here and keeping a post-down. You cut it in, the post-down properly, so that seals the back of the denture, but we can compromise and we can creep it forward. The fovea palatini would be about here, but I find that's an okay compromise for the patient with this. So anyway, this is Lynn. This is a lower denture, and it's fully extended beautifully. This is Monoplast B, all the way back up and over the retromolar pads. This shape is the same shape that I've been using for years now. It's developed by Dr. Abe, and this is his book here. It's a Japanese technique, and it's terrific. It really works well for getting suction, if we can, but also great stability. But here, let's have a look at here. Lovely occlusion, bang on. It's fantastic. And there she is with it fitted. And then she went away. And when she came back for review, she hated it. She hated the lower. She said, I want those. And this is the first patient that I've had seriously with the RBA system, where she did not want it at all on this retromolar pad area. Now, she wanted that cutting off, and she was adamant about it when she came in. I'm not wearing those. So, but I said to her, look, if we cut this off, the Monoplast B, the soft lining, will peel away. We can't do it on this denture. So what I said to her was, we'll make you a second set with a hard base that we can trim and use as a prototype like this. So went from Mark 1, which is a soft lining, to Mark 2. So we could cut this back edge off here and trim it away until she's happy. She can use fixative or something soft underneath that, like C-bond, and just make sure she gets away with it. And if she's happy, we'll then make Mark 3 with a soft lining. That was the approach I was going to do. So that Mark 2 was a prototype. Anyway, this is it here on the model. And so we trimmed away. You can see here, so if we go back, it fits right up the retromolar pad here. Trimmed it back. And we kept doing that over time. And this was over quite a few months. And I just wasn't getting anywhere. She said, this is what she wrote down. The lowers are just big and bulky everywhere. I just can't understand why I can't keep them in for long. I've tried the top and bottom together. They just don't work. So I was getting worried about this. She couldn't even wear the upper, which is weird. So she came in And I went through to the lab, and it's so lovely having Rowan next door in the room next door. He looked at the dentures and we examined them. We thought, look, the old one has much more tongue space than the new one. So we thought, And this was one thing that she just felt they were too bulky and cramping her tongue and making a gag as well. So what we did was, for the upper, we actually made a copy of the old one and just ditched Mark 1. We stopped using that and we went to Mark 2. And as soon as we did that, she managed with that absolutely fine. She could wear that all the time without a problem. So that was great. So we'd won with the upper, but with the lower, this was a different matter altogether. She was still not getting on with Mark II lower, because if you think about it, we'd gone to a wider upper Mark II with the teeth out, and then that lower was still inwards and cramping the tongue, and the bite wasn't quite correct on that. So what we needed to do, because Mark II lower was just going nowhere, we thought, because of this gagging issue, this restricted tongue space, we thought we'd do what I used to do for some cancer patients, was like a neutral zone technique. It's something that we use in hospitals for patients who've got altered morphology, but this can work quite nicely for this. So it's not a true neutral zone, but it is similar. It's a base. Now, how we do this is, it's a fin of acrylic here, which is on a light cure base that's just like the denture base there. And that fin fits up into the top teeth. And the patient occludes together with this in place and then performs movements. But I put visco gel. This is a visco gel. You could use Co-Soft on this. Goes into the mouth like that. The patient has a drink, sips, and then goes ooh, licks the lip, swallows, functionally molds this, and this produces a really narrow shape, but a really interesting shape here. So this is an impression of the soft tissues, and then from that we can produce a cast where we can then wax the shape of the denture up in a matrix here. This is a matrix of that shape itself. So we can copy the neutral zone impression into Mark III denture. So this was a hard base again, but it meant that we can try it in. You can see the teeth are really narrow there, super narrow at the back. We can try that in, fit it, and then we can then trim it. But you can see here, this is it in the mouth, much more tongue space available. And it meant I could trim this denture here to my heart's content at the back there. So we trimmed it right the way down. And then, so this, at this point here, by this stage, Lynn was comfortable with this and was able to wear it. There, can you see how much more tongue space she has? She was able to wear it with some fixative. And this would have been months and months down the line, and we got some flowers from her, which was great. It's fantastic. So we knew we were onto a winner. So once we got to that point there, we knew that Mark III, this one here, that's got a hard base on. This is because we could just trim it to our heart's content. We then replicated it, Mark IV. We're in this, it's exactly the same footprint as Mark III, but with proper sized teeth on and with Molaplast B on it. Here, soft lining, so she can wear that more comfortably. So this was it fitted. This is the occlusion that I like on dentures. Freedom at the front there, no contact on the anteriors, positive on the premolars. Anyway, off she went, and she managed with this beautifully. She could eat beautifully. And then she broke it. She broke the lower and snapped it, which meant that Rowan had to then repair that and redo it. The monoplast is it's almost like having to make a new denture. Anyway, we knew we had to do something about this. And we learned from this that soft lining lower dentures, we need to make them with metal reinforcement. So this is a chrome mesh, really rigid chrome mesh it's been opaqued and painted, but that can go inside the denture. So we now made Mark 5 lower there with this chrome reinforcement, exactly the same shape as Mark 4, like that. So you can see there, it's got that lovely monoplast lining on here. Embedded inside that is this strong cage there. So, and also we made, for good measure, we made a separate upper as well. So she went away with Mark 4 acrylic base upper and lower with monoplast on the lower. And Mark 5, we made another upper against the lower Mark 5. And the lower was metal and reinforced. And there she was, finished. So she's got like 2 sets of dentures, happy as anything. You know, she could eat, you name it, not a problem. It's fantastic. And then we got loads of flowers and she was super happy. She brought in some wine and some fudge and other things. It was great. And she wrote us this lovely card just to say that she could socialize again, she could smile again and everything. It was lovely. And then she cracked her upper. This was the acrylic based upper. Can you see that little fracture line in it? And you know, this is just no good. I hate it when dentures crack because the patient's confidence in the prosthesis just falls away. So what we decided to do was make a metal framework that fits within the denture itself. So so we use the actual denture itself, but make a metal framework with these little feet that go in. I've got one here that we're just making for a patient at the moment, but this is really quite special. Those little backings support the anterior teeth and stop it cracking, but we also maintain the exact same polished surface of the denture with that acrylic over the top, so that Lynn would be totally used to this. So you can see the acrylic in place there. So here she's got the upper and lower metal reinforced dentures. The monoplast B soft lining is here on that lower. And here we are at the end of that massive journey. I'm exhausted telling you about it. So that's what she paid at the top there. And I'd planned, this is like my normal complete denture. And I knew it was tricky, potentially 7 hours clinical with 10 visits and 12 hours technical. It actually took me 52 hours clinical with 42 visits and 60 hours of Rowan's time. So that was a massive loss leader, hugely subsidized treatment, but she can eat away with it. And I just want to share with you what she told me afterwards. I've got a video here. So I'm just going to play this video. Now, she's got a very strong Lancashire accent. It's a proper Lancashire accent. But she's telling me about, I felt like giving up partway through the treatment. I was really worried personally that we were not going to get there with this. She felt that I was going to give up, and she's telling us about this now. So turn up your sound to listen to what she's going to say, please.
And there were so many times, and I will be honest, there were so many times because I had so much confidence at the beginning, and things just didn't go right, and I thought, he can't do it, this man's not going to be able to do it, you know. And I thought, what if he gives up? And I thought, he can't give up, you know. And I didn't want him to give up, and I thought, please never give up, just carry on, you know. and then I started to feel that we're going to come together.
And it did.
And it all did.
Hey. And then she also here, this is quite important, it's quite interesting this, she can eat anything. So she's going to tell us about eating food with this.
No. And I can go to a restaurant, I can choose whatever I like off that menu. You know, you don't have to think I've got to have soup, because I hate soup, you know, because I've had that much. And so when you can just choose anything, I know it sounds a bit silly.
So, and then also, this is quite important, I think, here, that she was really, prior to me treating her, and I feel like really, it's just wonderful to have been able to manage to get a good result for her. But she really was so grateful to Khaled, who referred her to me. So this is what she was saying about the referring dentist too.
At the moment, that chap told me to come here. He said, well, I know someone, you know, he's not cheap, he said, but he'll sort you out, you know, he can do it. Now, if I hadn't gone that day, I still wouldn't have known about this place.
No.
And there must be hundreds of people.
Yeah.
You know, when you look at it, I feel sorry for people, mate. I do. I look at them and I think, oh God, go and get some teeth.
So, thank you very, very much indeed for being here tonight with me and sharing, you know, letting me share these experiences with these patients. So now I'm going to answer loads of questions, you know, that's in chat about this. But also, if you're interested, I've got some other webinars coming up. I'm doing immediates tomorrow. So that's more in detail, a bit like doing those special impressions like I did for Liz at the beginning. I'm doing implants next week as well on Tuesday, and then a massive Q&A session on anything you want to send through to me for the 12th of May. Thank you very, very much indeed. And I will now stop sharing my screen and have a look at you again.
Fantastic. I think, firstly, thank you to Finlay for an amazing lecture. I think all the guys and Kish myself will be able to agree. Absolutely fantastic. And even we learned a lot from it. I think from the last video you showed of Lynn, when she goes, he can't give up. I'm like, yeah, he definitely can't give up, because the next person after him is God. So if you give up, you've got nothing. And I think a lot of the guys probably want your phone number on speed dial. So we'll be like, I know a guy up north who could do dentures as well. But again, genuinely loved your passion. And what I loved was purely evidence-based, using your experience, but also the theory and the journals and everything to do the cases. But absolutely loved it, and the passion. And I picked up a lot of new things as well, especially the way you communicate to your patients and wish lists and a lot of little things, which is fantastic. Kish.
Yeah, I was just going to say pretty much the same thing. I think thank you so much for sharing those cases. And again, just showing that, you know, when you've got a difficult case, as you did there, you didn't give up. And, you know, it's just one of those things, especially to the younger dentists that we've got, the students, you know, things may not always go as planned. Even when you price up a treatment plan, it may not be, you may not find that it works out to whatever price you put out there at the beginning. But I think it's one of those things, just keep persevering and do the right thing, which is provide the treatment for the patient, which is exactly what you did.
Yeah,
and
one of the most important things I picked up in that was, you know, I think when we're looking at the special trays, you mentioned that most important slide was the correct extension of your trays. And I think that's something that's quite massively overlooked when we're doing dentures.
Yeah.
I mean, the one thing I picked up is, instead of remaking a denture and calling it a remake, I'm going to call it Mark II, Mark III, Mark IV. It sounds like iPhone 6, iPhone 7, sounds like an upgrade, then a remake. So I'm going to do that from now on. I like that.
Totally.
Yeah.
Jen, you're right, because they are like it's like a diagnostic set. So your first one's like a diagnosis, and your second one's you're getting towards the right thing. So it is. It's not just a remake. I think that's very, very true, Jen.
Yeah. But again, I mean, I appreciate, I think for the younger generation, or a day where everyone, you know, is on social media and seeing perfect cases, someone like yourself sharing from your failures and something which you improved on is quite good for everyone to see. And I think even myself and Kish, that's what we've learned from in our career. When things come back and fail, you improve on it and learn from it. So I appreciate your honesty with that as well. We've got a few questions. And
Cool.
I think one of the last slides you showed in your presentation is where you said you prefer this occlusal scheme where you leave the front teeth out of occlusion. So my question is regarding balanced occlusion, canine guidance. When do you use which one, and what are your thoughts on it?
Okay, I have a very, very simple occlusion. I've got actually Prani Sharma. Hi, Prani, it's fantastic that you're here. You are dead right. You've put down thoughts on bolus in, balance out. That's exactly my thoughts. As soon as we put food in our mouth and start eating, then all this balanced articulation is just non-existent. So it's all down to the way the dentures fit on the gums, on the saddles, and also how controlled the patient is with keeping them in place using their cognitive learning capabilities. So my thoughts are on occlusion is we must, if at all possible, record centric relation accurately. CR is king. If we can get that, then we are home and dry. Balanced articulation is not crucial. Like you said, I think you could give people canine guidance and it would be fine. And there's actually some good papers to show that giving people canine guidance on dentures is still quite effective. There's a professor called Professor Slavicek in Austria who really advocates that technique, and there's some randomized trials looking at that. So it's all about balance, just getting centric relation, and also trying to train the patient to be a chopper, not a grinder. So think like a crocodile, like that, not like a sheep. So, and because essentially dentures are prosthetic replacements for a body part, they do not operate like natural teeth. So, so don't get hung up at all about balanced articulation. Just record centric accurately, and it's great. And also try to just keep the teeth so you've got good positive contact on the teeth in the middle of the denture and no contact, very light contact anteriorly and further back. So basically when the teeth bite together in CR, it's keeping them nicely supported and evenly sitting on the arches properly. So the key to the occlusion is getting it on the 4 and 5 and mesial of the 6 positive, light everywhere else. That's
fantastic.
Perfect.
Thank you.
We've got a question. We've got a question from Ricky Bopow. He earlier today told me he was your #1 fan, so just a little shout out there for him.
Thank you.
He goes, thank you, Finlay, for sharing beautiful cases. Is there a benefit of using an Archon versus a non-Archon articulator?
Not really. I don't think, Ricky, actually, because I like Archon articulators because they are just like the human skull.
Mm-hmm.
I've got a skull over there, actually, but they just operate. So you've got the hinge in the same place, whereas the non-Archon is the opposite way around. And my brain's simple. I can't work it out if it's the opposite way around. I want it like the human. So that's why I just prefer Archon. But I have no preference over articulator systems, really. We use the Danar system in the practice just because we've had it. We've got 5 articulators at the practice and they're all Danar. And I don't want to change, really. But if I was going to change, I might go for a Cavo or I might go for a Stratos. It really, it doesn't matter as long as it's a quality one. There's lots on the market, they're good. So, thank you.
Thank you. Perfect. We've had quite a few questions about the longevity of the Molar Plus liner. How often do you have to reline it?
Yeah,
thoughts on that?
it's a good question. Absolutely. So the Molar Plus lining lasts for about 18 months to 24 months. That's what I say to my patients. Now, I do find in practice that it actually lasts longer than 24 months. And what my advice to the patients is to brush it with not using denture cream or toothpaste, but brush it with liquid soap, a bit like Fairy Liquid, and a normal toothbrush, and just clean that gently, get all of the debris off, soak it for 20 minutes in hypochlorite solution like Milton, 1 in 20, and then in water after that. And then it's actually not too bad at all. It's very straightforward to reline it though. You know, if they do need it redoing at a later date, it's a nice silicone wash impression and then just get that lining replaced. But it does take Rowan a bit of time. He needs to have a good 3 to 4 days to do it. So the patient needs to be without the denture for a little bit of time, which is a problem. And sometimes I'll make them 2 dentures with it on, so they've got a spare.
Perfect. Thank you.
Also good. Question here, why not use silicone material for your secondary impressions?
So that's really, it's a very good question. In terms of the, for upper dentures, for complete upper dentures, I love using alginate because it flows beautifully and it's hydrophilic, so it loves the moisture. And that's why I prefer alginate over silicone. But the key to great impressions, and this wasn't on today's presentation because of, you know, it's just an hour's talk, it's border molding. Border molding with green stick is key, and then it doesn't matter what you really use, it's whatever you find works in your hands. So if you like silicones and you find that they work better than alginates for you, use silicone, it's fine.
Brilliant. We've had a few questions.
Sorry, I was just going to say, while we're on the topic of impressions, someone asked, how do you take an impression of a flabby atrophic mandible ridge without compressing the ridge?
A flabby atrophic mandibular ridge. So I would do that in alginate, and then I would put right on the crest of the ridge. So I'd just do it. I wouldn't do an open tray or anything fancy. So, but just over the crest of the ridge, where it is flabby, I would look at it in the mouth, move it, and then just with a pencil, draw on my definitive cast where it is wobbly. And then I would get Rowan to put tin foil over it to put a space on. And then the denture would have space underneath, a bit like this. This is an upper torus, you know, so if someone's got a hard torus there, what we put is tinfoil on, it's got space on it, and it just means that the denture doesn't rock on that torus. Exactly the same principle for a lower atrophic ridge.
Great, thanks. I think that's a really useful tip actually, because I think a lot of us have issues with that sort of atrophic mandible.
Yeah.
Perfect.
There were a few questions regarding the metal ring in the first case.
Yep.
So one of the questions was the extent of it, the specifications related to it, and also do you need to do any adjustments to it to fully seat the denture?
No, I don't actually. It just lips over the top of the tooth. So it's just like a little ring rest that just fits over. So it will be about 2 millimeters in width around the top of the tooth, and it's just almost, it's a circumferential. It goes all the way around, and I find that because that, I very rarely have to touch it at all and adjust it. However, if when I came to fit the denture, it was holding off on that metal, it wasn't seating fully, then what I would use is occlude spray on it. So that powder spray onto the fitting surface of the metal, push it over the tooth, take it out, and where the occluder's rubbed off, I'd drill away those little areas and then try it in again, and just do that over and over until it sits fully down. But if it's made really nicely, it's not a problem. In terms of actual size specification, I don't actually have any. I just, Chris, my chrome technician, just makes it. So if I can find out exactly how thick it is, if you just send me an email, if you want to send, I can answer that and send that to him. Not a problem. Just direct message me on Facebook and I'll find out.
And Kalpesh had a question along with that. Would you have put any rest seats on these molars to help with this denture as well in the first case?
Yeah. It's a good question. That's very, very important. So quite often the molars are a bit divergent. So say your upper molars are like divergent. So the outside of the molar, what I have to do sometimes is use, I like a rugby ball diamond. It's a Shofu crown prep diamond, but it's like a rugby ball diamond. And I just take that around the edge of the tooth, and then that just allows that metal ring just to fit over properly. But one thing I do have, we look at very carefully, I know this is like, you'll be thinking of dental school surveyors, what are they for? They are so important, and we use surveyors in the practice all the time. So we look at teeth, the angles of teeth, and I do little adjustments of teeth a lot to make these things work. It's a really important question. So I first use that diamond, and then the second burr I use is an enhanced finishing burr just to polish it.
Brilliant.
That.
And we've got a message here from Brett Davis. He's from Australia. So we've gone all the way out to Australia today.
Hey.
He's saying his heroes are McGregor, Besford, McCord, all his heroes. And I'm just looking at the attendee list. John Besford is actually tuned in today and he's watching it.
Yeah. Hi, John.
John is watching it. If I knew that, I would have got him on here as well. It would have been a fantastic discussion. Not that myself or Kish would have any input, but it would have been good.
That's great. Thanks. That's lovely, Brett. It's great that you tuned in from Australia. Thank you.
We've got another question here. Copying dentures on a patient whose existing occlusal wear is really high. Do you replicate it? What do you suggest with flattened cusps and stuff like that?
Actually, this is it's a very, very good question, because me and Rowan hate copy dentures. And the reason is that we see so many faults with the dentures that they come in with, that the patient comes in with, that Rowan has a word for it, and I'm going to tell you it now. He calls it shit shining. So I don't like swearing like this, but that's what he does, because it's like trying to make something bad good. So you may have very worn occlusal schemes, yep, but I bet if I looked at the denture, it would be overextended in some areas. It wouldn't go up over the retromolar pad. There'd be stuff that just needs to be changed. So I just much prefer to start again, because it's so rare that I see dentures that are any good come through. I think John Bestford would disagree with me on that one, but he's not on the panel tonight.
He's really shouting at the screen now.
Yeah.
I love it. We've got another question from Harjot here. So Harjot is doing a specialist training at Eastman. It's a future pro specialist. He goes, do you feel it's necessary to do some tissue conditioning prior to impressions if the mucosal health is poor or inflamed?
Yes, I do. I think that's a really good point. So now, if the patient's got like loads of hyperplasia, sometimes you get these dentures that have been ill-fitting, and then you've got a growth of tissue over it. And so in those cases, what I would do is I'd adjust their current denture and put some Co-Soft or some Viscogel in just to condition the mouth and make it better. So yes, I think it's a really good point to do that. I think you can come unstuck with patients, though. I don't insist that they don't wear them, because they may, for their dignity, still want to keep their dentures in. So if we work around it, so even if there's like little bits of hyperplasia or an old post-down position, when I come to do my definitive impressions, I find it doesn't affect the fit of my dentures too much, though. I don't get hung up about it, put it that way.
Yeah, perfect. There are quite a few questions. Oh, go on, Kish.
Yeah, I was just going to say, there's quite a few questions on the best way of recording CR accurately without using the central bearing plates or the Gothic arch tracing.
So the best way is to use these pivots here. These were designed by Fraser McCord, Manchester rims, that's what he called them. So the upper, you trim the upper rim, which is as normal, like that. And then the lower is, you trim the lower to get the correct occlusal vertical dimension. And then you make sure that they both marry up together with the patient in centric relation. So what I do is, and this is, I don't do this method because I just want to get accurate CR. I use the Gothic arch. But if I was in NHS practice or in a, where funding was restricted, I'd use these all the time. And so, and they're great because the front section isn't on there, and it means that it's much easier to get these to touch together at the same time without the base tipping. So, and you just coax the patient into CR. So it's open wide whilst holding it down, curl your tongue back, try and touch the back of the upper denture and close together. And I want to see that open and closing reproducible. So I would just draw a line on here, draw a line on there that corresponds to each other when they're touching together, and make sure that just touches together at the same time. And then once I'm happy, cut a groove in on the top and bottom, a good positive groove, close together, Futar D, blast it in.
Perfect.
With the nurse, with Claire holding the lips apart with retractors, so I can see what I'm doing.
Excellent. I think that's a really useful tip there. I think we'll start using that as well.
Thank you.
Drumil Shah is one of our technicians. He's asking, do you prefer fully anatomical posterior teeth or semi-anatomical, and why?
Drumil Shah, that's a clever one. So I prefer anatomic teeth for my patients on the posteriors because they look better than, say, flat ones. But there are two different types, and I think Drumil, you've spotted it perfectly. Shotlander produced two types of back teeth, posterior teeth. They produce P range, which have got shallower cusps, but they're still anatomic, but shallow. And I prefer those for the older patients if they've got flat ridges. Shotlander produced the S range, which was developed by Slavicek, which have got big cusps, and they're just like, you know, a 20, 30-year-old person's teeth, back teeth, with proper big cusps that have not worn down. And I use those for younger patients. So that's, I know it's not like hard and fast rule, but so P range for old ones, S for younger ones. And I quite like the S ones for overdentures because they're really good, positive chewing teeth. So great question. Thank you.
Thank you for that. We've got another question
Right.
here from Marcel saying, with poor neuromuscular control, do you think a neurocentric occlusion is the only option? Would you try bilateral balanced occlusion regardless?
What's the neurocentric? I'm not familiar with that concept.
That's why I just read it out. Couldn't know my.
It's all right.
We'll
Let's,
see Marcel
sorry,
elaborate.
it's all right, Jen. Could you just repeat it again? I'll just think about it. I might have it totally wrong. He could write it in again, couldn't he?
He's just
Marcel.
Yeah, so Marcel in the chat box, he's written with poor neuromuscular
Oh, yeah.
control.
Hi, Marcel. It's good to have you here. Marcel's American. Let's have a look. With poor neuromuscular control, do you think neurocentric occlusion is the only option? Would you try bilateral balance? Neurocentric is when we use zero angulation cusps. Now, Marcel, this is a good question. I wouldn't use neurocentric or zero angulation cusps. I might not be answering your question totally right, but I did my PhD on denture occlusion, and so we trialed anatomic posterior teeth, lingualized occlusion, and monoplane, which was like 0-degree teeth, flat back teeth. And we found in this randomized trial that lingualized and anatomic were better than zero for all type of patients, really. So, so Marcel, I would just not use zero angulation cusp, but I might be wrong with what you're asking there. But you can send me an email and we can discuss it. So it's fine. But thank you.
Fantastic questions. Kish, was there anything else?
I think that was the last question. Yeah, I think we covered
A
all
lot
of
of
them.
people are asking in terms of your technician, can we use him? I said, "How can we use him? Can we take him?"
You've got it locked up in cupboard behind you.
So yeah, absolutely. He's do you know what? Because unfortunately, no. It's just because I see patients like 3 days a week, and that generates, and that's just purely dentures. I don't do anything other than that, and that generates more than enough work for Rowan. So he's like busy 5 days a week. In fact, we've got an apprentice who started as well, Sam, and he's brilliant, and he does 2 days a week. So we are, you know, we just don't have any extra capacity, unfortunately.
Okay.
That's okay. I mean, my question to you, obviously, you've got a fantastic stage in your career. But if you look down back at yourself as a newly qualified dentist or an FD, what advice would you give the guys? Or would you have changed differently with your career? Or
So I don't know. That's a really, Jen. That's a good question. I would. There's one book that I would have loved to have read 20 years ago, and it wasn't out then, 20 odd years ago, and that's called Peak, and it's written by a Swedish psychologist who's based in America, and he's called Anders Ericsson. Anders Ericsson's written Peak, and it talks about how in our life, none of us are born brilliant at difficult to do stuff. So none of us are born brilliant at making dentures or being a dentist. Dentistry is hard. You know, we've got to manage the patient really well, and we've got to be really good with that person. We've got to be great with our team, with our nurse, but also we've got to be really good with our hands and have very good sort of, you know, beginning with the end in mind, and have good mental images of what we're trying to produce. It's a very visual thing that we're doing. So, and Peak describes in detail how to get good at difficult stuff. And it's a step-by-step process of deliberate practice. And so I would have loved to have read that book, because it would have guided me quicker to where I want to go. But I don't, seriously, I think that, you know, I do prosthetics, and life is, I would never have dreamt I would have done dentures. It's only because I met Fraser McCord when I was doing my masters that he loved it, and he got me into it. And I met Rowan, my technician. So I think the advice is, take the opportunities that present themselves and go for it, and don't live in regret. You know, just if an opportunity is there, take it, take that mentorship and really go with it, because life is amazing. I met John Besford, and everything changed 10 years ago with what I'm doing. It's wonderful.
That's amazing. And this is something which, I mean, myself and Kish, very similar when we heard your talk at the Tubules conference with John Besford. And a lot of it was on the mentoring. Myself and Kish, I mean, I wouldn't be here if it wasn't for my mentor. And he's on the attendee list today, Sumer Khan, who was my FD trainer, who sort of paved the way for me to get to me where I am. And I think finding a mentor is so important to help you in the career as well. Kish.
Yeah, I can only echo what Jin's saying. I think that is probably one of the most important things, and that's what we advise all the young dentists coming out nowadays is, you know, find yourself a mentor. And I think, Finlay, one thing that I respect about you so much is that I know you've said before that you never thought you'd go down the denture route, and you found dentures difficult, as we all have found dentures difficult, especially as a student or as a FD. It was one of the main things that was kind of unpredictable and can be quite stressful at times. And then you managed to grab the bull by the horns and literally go and become excellent at it, which I respect a lot.
Thank you very much.
Brilliant.
And also, what I think as well is just the final little thing at the end is that I think being good at dentures, or being good at actually positioning artificial teeth, is really so vital for implant work too.
Yeah.
So it all goes together with it. So I think that's something that's really, really important. I think sometimes we forget a little bit about that too.
I think that's very true. And especially in the current climate where aerosol generating procedures we have to be careful with, a lot of us will be doing extractions and dentures. So
Yeah.
I think it'll be a very important thing in practice when we go back, hopefully quite soon. But I'm just going to check any more questions at all or anything. I think we're good.
Oh yeah, there's an acupuncture course here. SM's asked about that. What acupuncture course? There is a really superb course at Liverpool Dental School. If you look on Health Education England, it's run by a oral surgeon called Tom Thayer. Tom Thayer, HEE. It's a day course on acupuncture for dentistry. It's really good fun actually as well. But it's great, you know, if you've got that in your toolkit for these patients that do gag, it's brilliant.
Yeah, I was going to suggest definitely go on a course. Don't just start sticking needles in gagging patients all over the place. In the middle of the tune, bang it in.
That's right. Yeah.
Brilliant. So once again, look, thank you to Finlay for his time. Appreciate, again, Finlay's got his own lecture series. We'll be going to specific topics. So again, please do go onto them. They're on his website. And also, as Finlay said today, all his material in terms of his lecture stuff is available on the website as well, which again, I appreciate. Share the love, share the knowledge, what Finlay is doing. So do go onto the website as well. Next week, we have got Marcus Blatz from the US, who'll be joining us at 8 o'clock. So do register for that. Otherwise, if we do not have any other questions at all, once again, big thank you, Finlay. Appreciate it. And those of you guys on our academy will be having Finlay for the complete denture module on that as well, which we'll be seeing hopefully later this year when we can go back to Northwick Park. But again, thank you so much. Everyone keep safe, keep healthy. That is us signing out. Finlay, thank you so much. Kish, thank you. And everyone have a lovely week. God bless everyone.
Cheers. Thanks, Finlay.
Thank you. Cheers. You're welcome.
Yeah.
Thank you.
Thank you so much.
Bye-bye.